My name is Sarah Omer. I'm one of the Yale Internal Medicine residents, and this is the Yale20 presentation on acute liver failure. I would like to thank Dr. Tamar Taddy in the section of digestive diseases for her help in putting together this presentation.
For the rest of this presentation, we will refer to acute liver failure as ALF. We will start with a 5-minute bedside assessment, going through the initial evaluation of a patient suspected to have ALF. We will walk through the diagnosis, etiology, and workup. We will talk about the management and complications of ALF. Finally, we will put it together in a sample write-up.
Before we start the bedside assessment, we will review the criteria for ALF. It is defined by the onset of jaundice, encephalopathy, and coagulopathy, with INR greater than or equal to 1.5 in adults without a history of chronic liver disease. To be considered acute liver failure, the duration of presenting symptoms must not be greater than 26 weeks. Now, the significance of ALF comes from these 3 findings in the given time course. This constellation of findings over a short time course indicates a rapid decline of liver function, resulting in altered mental status and coagulopathy in previously normal individuals. ALF patients are, by definition, very sick. They're at increased risk of multi-organ dysfunction at all stages of presentation. We will talk about the pathophysiology and management of these later, but they include cardiovascular collapse, progressive hepatic encephalopathy requiring invasive ventilation, cerebral edema and intracranial hypertension, potentially requiring neurosurgical interventions, renal dysfunction requiring dialysis, infections, and bleeding. Because ALF has such poor prognosis, it's a very important diagnosis not to miss. All patients with clinical or lab evidence of acute hepatitis and any level of confusion should have immediate measurement of their INR to rule this out.
So, we get called to evaluate a patient suspected to have ALF. For starters, we must evaluate quickly for life-threatening complications mentioned in the previous slide. Initial assessment and management goes through the following. Is the patient hemodynamically stable? If not, do we need to give fluids or pressors, and how much? How sick do they look? Jaundice, nausea, vomiting? How rapidly is their mental status changing? Can they protect their airway? Do they need to be intubated? For patients with progression to grade 3 and above, the recommendation is to intubate and sedate as soon as possible. We should look for reversible causes since specific therapies may be available. These are potential ingestion or overdose of acetaminophen, mushroom poisoning, and ischemic liver failure. It is important to ask for history or family history of Wilson disease, where the only treatment of acute Wilsonian crisis is transplant. Some of the major initial labs include CBC to obtain a white count, differential, and platelets, electrolytes and renal function, and glucose level. Perform an ABG. Ammonia should be trended. Lactate should be performed to evaluate for ischemia. Check an acetaminophen level. Do a pregnancy test for all females, and surveillance blood cultures should be done at baseline for infection. After the initial evaluation and management, the next step is to transfer the patient to an ICU right away, preferably at a liver transplant center. ICU is the best place for monitoring that is frequent enough to catch the rapid hour-to-hour changes in mental status and organ dysfunction. When treating a patient with ALF, it is also very important to have the liver transplant service on board.
Now, let's talk about some of the etiologies of acute liver failure. 50% of ALF in the U.S. is caused by drugs, and over half of that is due to acetaminophen. The response is dose-dependent. Most of the time, for example, in a single suicide attempt, the amount of acetaminophen is over 10 grams a day. However, it can be seen with smaller doses taken over a long period of time for the purpose of analgesia. There are many other drugs that are known to be hepatotoxic and can cause drug-induced liver injury that can progress to ALF. In this table, we can see that antibiotics, NSAIDs, and antiepileptics are commonly implicated. Most reactions occur within 6 months of initiating the drug. There are many other drugs that are associated with liver toxicity, and these can be checked at the NIH website for drug-induced liver injury. Viral hepatitis, specifically hepatitis A, is another common cause. Even though it accounts for only 12% or so in the US, globally it's the most common cause of ALF. Hepatitis B reactivation is also common after initiation of immunosuppression or chemotherapy. There are also rarer viral causes of ALF, such as herpes simplex, cytomegalovirus, Epstein-Barr, and parvoviruses. Other causes of ALF are shock liver or ischemia, autoimmune hepatitis, Budd-Chiari syndrome, pregnancy-associated ALF, including HELLP syndrome, and Wilson disease. Mushroom poisoning is another cause of springtime ALF, especially on the West Coast.
In many cases of ALF, no cause can be identified. In this chart depicting outcomes in ALF by etiology from the U.S. Acute Liver Failure Study Group, you can see that in cases where the cause is indeterminate, many of these patients required transplant or died before transplantation, as denoted in the purple and blue bars. The prognosis is also worse with Wilson disease and with infiltrative malignancies. You can see in the infiltrative malignancies category that every patient died because transplant is contraindicated in this population. One theory is that etiologies that are indeterminate follow a subacute presentation and may have signs overlapping with chronic liver disease, and therefore they take longer to recognize and to initiate treatment. On the other hand, you'll note that the spontaneous survival rate in acetaminophen toxicity, shock, or pregnancy is much better. This is shock and this is pregnancy.
After initially stabilizing the ALF patient, we move on to the workup. During the history taking, it's important to go through all prescribed and over-the-counter medications, as well as herbal preparations, supplements, and home remedies. Pay attention to antibiotics, antiepileptics, and NSAIDs. You should ask about pain issues and analgesia with medications containing acetaminophen, such as Vicodin and Percocet. You should ask about psychiatric history and entertain the potential of intentional medication ingestions. If a patient presents with a recent history of nausea, vomiting, diarrhea, ask whether they have foraged for or eaten mushrooms. It's also important to find out the amount, timing, and duration of consumption when reviewing the medications. Other clues from the history include potential viral causes and recent travel history, history of malignancy, hypercoagulability, previous deep venous thrombosis, and family history of Wilson disease or autoimmune hepatitis. If your patient is critically ill, hypoxic ischemic injury arising from cardiac arrest, blood loss, and sepsis should be the top of your differential. And the potential of pregnancy should also not be missed, as ALF can rarely present in earlier trimesters. Physical examination must include a search for stigmata of chronic liver disease. History or signs of cirrhosis, such as spider angiomata, palmar erythema, a palpable spleen, suggest underlying chronic liver disease, which has different management implications and prognosis. Jaundice and right upper quadrant tenderness are often seen at presentation, but not always. And the lack of these symptoms, especially in hyperacute cases where confusion or agitation is the dominant presenting sign, may delay the recognition of ALF. Massive hepatocyte loss can manifest as a small shrunken liver, but an enlarged liver may be seen in viral hepatitis or with malignant infiltration, or acute Budd-Chiari. Finally, if there's any concern for Wilson disease, a slit lamp exam should be done. 50% of patients with Wilson disease causing ALF have Kaiser-Fleischer rings.
The diagnostic workup sent for ALF should be broad enough to entertain most causes because history taking may be limited in the encephalopathic patient. Other than the basic labs mentioned in the initial evaluation, many other labs can be obtained to clarify the underlying causes. These might include a comprehensive toxicology panel looking for cocaine in an MDMA, which can present as an ischemic type picture. A viral hepatitis panel, including hepatitis labs for A, B, E, CMV, EBV, HSV, VZV, HIV, depending upon your suspicion. Ceruloplasmin, serum and urine copper levels for Wilson disease should be sent in the appropriate patient. ANA, anti-smooth muscle antibody or anti-F-actin antibody, and anti-LKM for autoimmune etiologies can be considered. A hypercoagulability workup for factor V Leiden and lupus anticoagulant may also be considered. Imaging with CT or MRI can be considered based upon suspicion for acute malignant infiltration, and an abdominal ultrasound with Doppler should be performed to assess the parenchyma, the vascular patency, and the direction of blood flow, and to specifically evaluate for Budd-Chiari syndrome, which is hepatic vein thrombosis, or other outflow obstruction. Whether a liver biopsy is needed is often decided on a case-by-case basis, depending on the suspicion for Wilson disease and autoimmune hepatitis, and to elucidate an indeterminate etiology.
Now for treatments. N-acetylcysteine is the treatment for acetaminophen toxicity. We can see in this pathway that acetaminophen metabolism creates an intermediate called NAPQI, which is toxic to hepatocytes. Normally, this doesn't happen because there's enough glutathione around to convert NAPQI to the non-toxic mercaptopuric acid. When the levels of acetaminophen are so high that the glutathione is depleted, NAPQI builds up and hepatotoxicity occurs. N-acetylcysteine works by increasing the synthesis of glutathione, so the toxic metabolite can be cleared. That's why we give NAC at the following doses on the slide in cases of confirmed or even suspected acetaminophen toxicity. It has few side effects and can be life-saving. No need to commit the doses to memory, as the pharmacy will mix it per protocol for IV administration. The Roumac-Matthew nomogram can be used to predict liver toxicity based on plasma acetaminophen level and time post-acetaminophen ingestion. When the level of plasma acetaminophen meets or exceeds 150 milligram, NAC is indicated. However, the nomogram is only applicable within 24 hours of massive ingestion, so it's not for chronic users, and it may also be confounded by the presence of other drugs or alcohol. Therefore, it's recommended to give NAC regardless of time since ingestion.
More recent data suggests that NAC or NAC is helpful in non-acetaminophen toxicity in adults. Many institutions, including Yale, now give NAC in ALF regardless of the cause.
Mushroom poisoning is also another cause of ALF, which has a specific treatment. Although there is no specific blood test to confirm the diagnosis, we treat on the basis of suspicion. For amatoxin poisoning, the most common type of mushroom poisoning, the specific antidote is silibinin. The IV form of silibinin is not currently available in the United States. An oral form, called silomarin, may be obtained. Silomarin is a dietary supplement found in health food stores as an extract from milk thistle. Silomarin is given at 1 gram orally 4 times daily, or its purified alkaloid silibinin is given IV at 5 mg per kg over 1 hour, followed by 20 mg per kg per day as a constant infusion. Silibinin interferes with hepatic uptake of alpha-amanitin. In hypoxic ischemic hepatopathy, treatment is based on good cardiovascular support to reverse the heart failure. In acute fatty liver of pregnancy and HELP syndrome, management involves prompt consultation of OBGYN for delivery of the fetus. Most viral hepatitis do not have specific therapies other than HSV and VZV, which may improve with IV antivirals. In autoimmune hepatitis, corticosteroids at 40 to 60 mg per kg may be helpful. However, the patient with fulminant autoimmune hepatitis should concurrently be evaluated for transplantation. Acute Wilsonian crisis mandates immediate transplant evaluation. Plasmapheresis may buy time. Budd-Chiari syndrome may improve with direct thrombolysis and anticoagulation, but the patient should concurrently be evaluated for transplantation. Malignant infiltration of the liver causing ALF is a terminal condition and absolute contraindication to transplant. Liver transplant should be a consideration very early on in the management in all cases of liver failure, especially where the cause is unknown or poor outcome is predicted. Because the longer the wait, the more likely the patient will develop an infection, multi-organ failure, and other contraindications to transplant.
Identifying patients who will not survive with medical therapy alone and who will need liver transplantation is very important and needs to be done quickly. One of the more commonly used prognostication systems for this purpose is the King's College criteria, which divides ALF patients into those with acetaminophen toxicity and those without. As we can see from the table, age, grade of encephalopathy, and level of coagulopathy are key prognostic factors. This system has good specificity but isn't overly sensitive, which could lead to unnecessary transplantation. It is also important that while transplant is a treatment option for some, it is not universally available. The rate of survival is about 79% at 1 year and 72% at 5 years, specifically in patients with acute liver failure. There are many other staging systems, such as the Apache 2 and the SOFA systems, which take into account function of multiple organ systems. These systems do not provide a superior predictive value as compared to the King's College criteria.